Hi, I'm Steve Selig, founder of FitTest. In this series of a couple of short videos on the topic of postural orthostatic tachycardia syndrome, big medical term for POTS, and this is directed to exercise professionals. So in part one of this 2-video series, I'm going to talk about what is postural orthostatic tachycardia syndrome, underline the word syndrome because that will come in a bit later, and also present a relevant case study. So POTS, I'll just shorten it to POTS from now on. And the unifying clinical feature of POTS is sustained increase in heart rate on standing or gaining upright posture. And this increase in heart rate simply by standing can be at least, or will be at least 30 beats per minute, which is much more than, of course, what the ordinary person would exhibit on standing. And this big increase in heart rate on standing is accompanied by either no change in blood pressure, normally there'd be a small fall in blood pressure, or even an increase in blood pressure on standing, which is most unusual. Normally when we go from a sitting or from a lying position to standing, blood pressure falls a little bit while there's some autonomic adjustments needed for the pooling of blood in the lower body on gaining that vertical position. Now the slightly confusing thing here, which I need to bring in here, is that postural orthostatic tachycardia syndrome, or POTS, is often accompanied by another condition known as orthostatic hypotension, which is where blood pressure falls much more than normal on gaining your upright position. So the whole issue around blood pressure is quite clouded and confusing. And this is why I would say that POTS is probably the most difficult condition or syndrome that I come across in order to be able to make head or tail of it to provide a safe and competent exercise service for my clients. And I would say at this point that the most important thing to do is to do vigilant sign and symptom monitoring and reporting if necessary in order to deal with the unusual constellation of symptoms that occurs in this syndrome. Now, to really define POTS or to be a positive diagnosis, the constellation of symptoms that I'm going to describe must accompany this increase in heart rate on standing for at least 6 months. So it's not an overnight diagnosis. Interestingly, there's a very high comorbidity with chronic fatigue syndrome, and in fact with a cluster of both neurohormonal and autoimmune conditions, very high comorbidity with POTS. The very noticeable thing, and this certainly is confirmed in my own practice, is that POTS is most frequent in young adult women, especially in the age group of 18 to 40 years. So the increase in heart rate, we don't need to be too concerned about where it's coming from, because it is coming from the safe part of the heart, the sinoatrial node, which is the normal pacemaker tissue of the heart. So it is described as a sinus tachycardia, which we all undergo when we go to exercise. It's just that we don't have this at rest when we stand up, and that's the difference. So this increase in heart rate is simply due to an increased sympathetic drive to compensate for a decrease in circulating blood volume on standing up, which is called hypovolemia. So you may not actually be dehydrated, but the volume of blood, which is supposed to be getting back into the right heart very quickly within a few seconds of gaining your upright posture, simply doesn't happen, and you can get some pooling of blood in the lower part of your body or elsewhere. So this is a relative hypovolemia rather than describing a dehydration condition. Now, going to the cluster of symptoms now, of which there are many and many non-specific to the condition of POTS, fatigue, headaches, especially migraines, lightheadedness, especially on gaining upright posture or even exercising, heart palpitations, in other words, the feeling of racing heart rate or even extra heartbeats. Exercise intolerance is a hallmark. Nausea, diminished concentration, which is otherwise known as brain fog, tremulousness or shaking, even sometimes fainting, coldness or pain in the extremities. And this is because the warm blood is not getting to the extremities to cause nice pink colour and get rid of the cold feeling. Chest pain, usually atypical because we're talking about young, often healthy young women, and so it's not usually typical of coronary artery disease. But of course, if there was significant coronary artery disease there, then this could be typical chest pain of angina. Shortness of breath, very non-specific, gastric motility problems, and many other symptoms. So there's a large cluster or constellation of symptoms for this condition, and that's why it is a syndrome, not a single cause condition. The signs can include dark red, blue coloured discoloration of the legs as it links into the coldness or pain in the extremities. Now, 50% of individuals with POTS have some form of autonomic neuropathy, and this goes with the whole cluster of conditions of neurohormonal and autoimmune as well. Now, the autonomic neuropathy in the case of POTS is really referring to an increase in sympathetic drive mainly. Interestingly, the evidence points to POTS not being caused by chronic anxiety. Now, POTS and exercise, seated or supine exercises are obviously safe in the setting of trying to prevent fainting, and also perhaps protects against the actual syndrome of self, and may protect against the extreme excursions of high heart rates that we get in POTS. Now, the recommended type of exercise in terms of aerobic would be rowing machines or recumbent cycle or swimming, and in resistance it would be the more seated exercise using machines rather than free weights. You can expect some very high heart rates at both low and moderate intensity exercise, and you can also expect the actual heart rate peak to be well over 100% of the age predicted heart rate peak, both during exercise and in recovery. Heart rate can stay very high as well. So just this diagram is a nice picture of the cluster of symptoms that can occur in POTS. And really I've just borrowed this image from Shutterstock, and what this shows is on standing, this female has undergone big increases in heart rate and also in blood pressure, which is quite typical of POTS. But the blood pressure excursions can be different. In fact, you can even have big drops in blood pressure and still be in POTS. So it's that characteristic rise in heart rate on standing, dramatic rise in heart rate on standing, that is characteristic of POTS. So now we come to the interventions. And the first intervention is to increase fluid intake. There'll be some individuals in which this isn't safe, and they should know that from other medical advice that they're getting. But generally an increase in fluid intake to decrease the hypovolemia and get blood back to the right heart. Increase in salt intake, which also deals with hypovolemia and preventing it. And in extreme situations such as emergency medicine, they may need an IV saline drip. Waist-high compression stockings and corset-like garments above that in the abdominal area can help to prevent or protect venous return and protect stroke volume, and thereby protect the blood pressure from falling, and that will be more in the case of orthostatic hypotension, and that in so doing it will prevent the very high excursions, or could prevent the very high excursions in heart rate. Exercise, I've already mentioned, supine recumbent exercise is recommended, such as rowing, cycling, recumbent cycling, or even seated cycling is somewhat better than, say, running or swimming and all of these considered relatively safe and effective for people with POTS. If many of these clients with POTS are severely deconditioned when they first present to an exercise professional, and so you need very gradual progressions, and avoid high intensity training or high intensity interval training. There's a device called impedance threshold breathing device, which will decrease inspiratory thoracic pressures through the extra work needed for breathing in. And this will have the effect of increasing venous return and increasing stroke volume and eventually blood pressure. And then via the arterial baroreceptors may decrease heart rate. The problem with all this, though, is on the right side of the heart, it can actually have an opposite stimulus in the right atrial stretch receptors. When they see a lot of venous return, that can actually cause an increase in heart rate. So to be honest, this device can have changes to heart rate in both directions. And in terms of my own caseload with POTS, I haven't seen a client with impedance threshold breathing device, but I just note it because it was in the reference by Raj in POTS below, and the other references by the same author. Pharmacotherapy then, beta blockers are considered first line because they have a direct impact on heart rate and quite a dramatic decrease effect on heart rate, 30 or 40 beats per minute typically, which will pretty much totally block out the opposite effect of POTS on heart rate of being 30 to 40 beats increase. So the beta blockers will be on paper effective. But what we have to remember here is most of the clients that we see with POTS are young, otherwise healthy women. And to go on a lifetime prescription of beta blockers is often not a good outcome for those women, causing fatigue and low blood pressures and so on. So there are other drugs available. Now, midodrine is given as an alpha agonist in the setting of someone who has low blood pressures, maybe with sympathetic, via the sympathetic pathways to then cause reflex increases in heart rate. So midodrine is given for people who are troubled by low blood pressures in the setting of POTS, and that this is a short-acting alpha agonist. So the effect is fully expressed at 1 hour post tablet, and the effect only lasts about 2 or 3 hours. So it's quite useful for people who have episodes of low blood pressure with comorbid big increases in heart rate. Ivabradine is a relatively new drug. It's a direct sinoatrial nodal blocker, and it will decrease heart rate without decreasing heart function or systolic function, which could then go on to produce orthostatic hypotension. So my understanding of ivabradine is, like midodrine, it's an effective drug in people who are susceptible to orthostatic hypotension, in the sense that it won't drop blood pressure further, but it will certainly act effectively on the sinoatrial node to decrease heart rate. Fludrocortisone I've seen in a number of clients who have presented to me in POTS. It's a mineralocorticoid, and it is a salt-retaining drug, which will then retain water as well and help that hypovolemia. And another drug, vasopressin, or the analogue actually, which is desmopressin, will increase water retention and likewise work against hypovolemia. So now we come to my first case study, and as you can see, this person not only has POTS, 46-year-old female, but also suffers from orthostatic hypotension, and that's quite relevant in this case. So she, first of all, in 2003, a long time ago, was diagnosed with polycystic ovary syndrome, or PCOS. And sometime after that, glomerulonephritis, which is a kidney disorder. And in 2014, POTS with orthostatic hypertension. So she's had it for a long while. The medications that she's on, there's only one drug that she's taking for POTS itself, and that's the ivabradine, which I mentioned in the previous slide. It is an anti-anginal, but that's not why it was given here. it decreases heart rate and without dropping blood pressure. So it's very good in this situation, as is midodrine. Now, the other drugs, I'll just put them all up. None of these are being used for POTS itself. So the irbesartan is just an angiotensin receptor blocker. It's actually an antihypertensive, so it's used for high blood pressure. And that's because within her POTS, she gets episodes of high blood pressure, which I mentioned right at the beginning of the presentation. And that's why this syndrome is so difficult to interpret and actually work with. And I'll come to that in my second presentation, which I would recommend you look at, because it really talks about the comorbidity and how the challenges we have in exercise, but we can exercise these patients very safely and effectively if we're careful. Metformin for diabetes and PCOS, well, in this case, PCOS, and she was also on an antidepressant made up of a serotonin and norepinephrine reuptake inhibitor. So exercise, coming now to exercise. She likes to cycle at moderate intensity for very long rides of 2.5 hours. So we're talking about someone who really loves her exercise, and it is cycling. And let's see what happens. She's got a very high VO2 peak of 39.3 for a 46-year-old female. So that's an excellent score. Her blood pressure peak is not a worry. That's during exercise. It's 188/72. That's fine. Heart rate peak, interestingly, as I said at the beginning of this presentation, hers was at 111% of her age predicted heart rate peak, which in itself is not a concern for me. When she coasted downhill, that heart rate was still in the range of 160 to 180, which was at or near her age predicted heart rate peak. And this is when she was coasting downhill. But when she did coast downhill, she experienced dizziness. In other words, when she took her foot off the big gears, she did experience dizziness, which is interesting because that would indicating that there's not enough blood getting to her head and brain. It was okay when she resumed pedaling. Now, post-exercise where the issue came, blood pressure at 2 to 6 minutes in passive recovery dropped all the way down to 70/50, and she felt like she was going to faint while walking around the house and doing light housework to try and keep her blood pressure a little higher. Her heart rate recovery at 2 minutes was 166. This is extraordinary for someone who is as fit as this 46-year-old female. At 60 minutes, 1 hour recovery, it was still 120 beats per minute. So we came up with a recovery strategy. So it was really all about recovery with a little bit of issues when she was coasting downhill. Obviously, we would prefer that she was riding on the flat. That would be a better strategy, but that didn't seem to fit in. And my concern with the symptoms when she's coasting downhill is that she could faint while riding at a very high speed downhill. That is a concern. We talked about that and we put strategies in place, but I'll come to some other strategies that may be possible in a minute. So we trialled a strategy where she lay down immediately on returning home. She lay down for 3 minutes. Her blood pressure was fine at 104/58, and her heart rate was reasonably okay. When she stood up, though, her blood pressure dropped through the floor and her heart rate went through the ceiling. Then she lay down again for another 3 minutes and a similar response occurred. Good drop in blood pressure, maintenance of blood pressure and a good drop in heart rate. When she stood up again, the same thing happened. Blood pressure through the floor, heart rate back up through the ceiling. So this strategy was not working. It may eventually work after 30 minutes, but I concluded that this is far from satisfactory. So I suggested that she get a second opinion from another cardiologist, who then went on to prescribe an additional class of drugs to help with this, and that was the drug midodrine, which I talked about earlier. And if this was taken either right at the end of exercise or as soon as she got the symptoms in recovery, the effect would last, would be fully expressed in an hour and would last for 2 or 3 hours. Now, the whole thing then is the timing of the midodrine. If it was me and I was only undergoing moderate intensity exercise, I'd be thinking about taking this drug while I was still riding. If it's a 2 hour ride, then maybe in the second hour, I'd be thinking about taking this drug to avoid the symptoms as soon as she finishes. That would be my suggestion. But of course, she needs to talk this through with her cardiologist. So thanks for listening to this quite tricky topic on POTS. And if you have any further questions, which I probably can't answer, info@myfittest.com.au. So have a great day, and please watch the second video on POTS for exercise professionals.